Hello, everybody. Welcome. Get started in just a couple moments. Good afternoon, everybody. We'll get started in just a moment. Give people a little bit more time to log in and get settled. All right. Thank you, everybody, for logging in. We're just about to get started. Awesome. All right. Good afternoon, everyone, and welcome to AAPI Immigrant Justice, a 5-part webinar series hosted by Asian Americans Advancing Justice Southern California, or AJSOCAL. My name is Mary-Lise Robinson, and I use she, her pronouns. I'm the National Policy Strategist at AJSOCAL. AJSOCAL is a social justice organization that protects and strengthens the rights and dignity of Asian Americans and Pacific Islander, or AAPI, communities, especially those that are most disadvantaged. As the nation's largest AAPI legal service and social justice organization, we advocate for policies that promote an inclusive and equitable community for all in which AAPIs are empowered and thrive. Thank you for joining us again today to learn more about AAPI immigration through the lens of data collection, healthcare, narrative shaping, and domestic violence and abuse. The AAPI community is the fastest growing racial and ethnic group, with over half of Asian Americans having been born in another country. That means that most members of our community are related to or are themselves an immigrant. Immigration is core to the AAPI identity and has broad-reaching impact on our communities. However, when we talk about immigration to the United States, it is often spoken in broad, sweeping terms, leaving out the nuance and unique experiences of immigrant communities, including the AAPI community. This renders our community's experiences invisible and susceptible to stereotypes or generalizations that can inadvertently cause lasting harm on our community's fight for equity and justice. Yesterday, AJSOCAL's research analyst walked us through the raw data, presenting the AAPI immigrant experience to us in the numbers. We learned how vast and diverse the AAPI immigrant community is and why aggregated data is so harmful for the AAPI community, particularly when it comes to topics like immigration, as well as income and homeownership. Through disaggregated data, we see how vast and diverse the AAPI immigrant experience is helping us identify equity issues and areas for advocacy. Today, we will dig deeper into one of those issues, healthcare. AJSOCAL's subject matter experts and community partners will tell us more about the unique and varied challenges AAPI communities face when seeking healthcare and how these issues intersect with immigration. As we welcome our speakers for the day to come on camera, I would like to remind everyone that we will be utilizing the Q&A feature. So please drop your questions in as they come to you throughout this presentation, and we will take some time at the end to answer as many as possible. And with that, I will hand it over to your moderator for today, Connie Lowe.
Good afternoon, everyone. I'm Connie Lowe. I'm the Health Access Director here at Asian Americans Advancing Justice, Southern California. I support regional collaboratives focused on healthcare reform, outreach, education, and enrollment. Before that, I spent almost 10 years with the Centers for Disease Control and Prevention and with the Centers for Medicare and Medicaid Services at the federal level. For our panelists, we have three amazing panelists joining us. First is Jack Cheng, who is the Chief Operations Officer of Chinatown Service Center, a federally qualified health center serving Chinatown, Los Angeles, and the San Gabriel Valley. He actively participates on advisory and community boards across California, including healthcare planning, public health, and community engagement panels. He holds both a master's in health administration and a Juris Doctorate degree. Jack, did you want to briefly introduce Chinatown Service Center?
Hi, all. Yes, Chinatown Service Center is a federally qualified health center. We've been around since 1971, so almost 55 years. I'm just really excited to be here with you all. Thank you.
Next, we have Zainab Qureshi. Zainab is the Director of Programs at South Asian Network. Zainab has many years of leadership and organizing experience. She has worked with individuals facing deportation while incarcerated and in immigration detention to connect them to legal resources and know your rights information, and is still an active member of the Orange County Rapid Response Network, where she organizes with systems impacted community members through the participatory defense model. She holds bachelor's in arts and international studies with a minor in Middle Eastern studies from Cal State Long Beach. Zainab, would you like to introduce the South Asia Network?
Yes, thank you, Connie. Good afternoon. Zainab Qureshi, as Connie mentioned. South Asian Network is a nonprofit based in LA County, and we've been around for about 36 years now. And we serve the South Asian population here in the areas of gender-based violence, healthcare access, mental health, civic engagement, and economic development. Thanks for having me.
And last but certainly not least, we have Alisi Tulua. Alisi is the Executive Director of the Southern California Pacific Islander Community Response Team, SoCal PICRT. She has spent the last 15 years in community-based nonprofit work, where she continues to receive the greatest and most significant education in her life over the guidance and mentorship of her elders. Over these years, she has contributed to NHPI communities through her work in cancer and health disparities, youth development, community organizing, coalition building, capacity building, and policy advocacy. She has a Master's of Science in Biology and a bachelor's degree in biochemistry and cell biology from the University of California, San Diego. Alisi, would you like to introduce SoCal PICRT?
Sure. Thank you, Connie. Thanks everyone for the opportunity to be here. Proudly here to represent the work that SoCal PICRT is doing. We were started as a coalition of 20 Native Hawaiian and Pacific Islander serving organizations across Southern California to respond to COVID. The community in our name was previously COVID. We were a COVID response coalition. We've stayed on to provide direct services to our population, specifically in LA County, where we don't have a social services organization. And so we help navigate our community resources for whatever needs that they have for their families. And I'm happy to be here.
Thank you so much, Alisi, and thank you to all of our panelists for being here. Alisi, talking about how SoCal PICRT got its start, I think is actually a great way to kick off this discussion about our health systems, access and affordability for AA and HPIs, really. Because how do AA and HPI community members, especially the ones that you engage with, think about health, talk about health, define health, and how does it differ from mainstream US ideas around health. The PI community was so hard hit by COVID, especially, right? And the fact that SoCal PICRT was a community response to target that disparity is something that I think is a really good place to start off this discussion.
Sure. I think that very similarly to many of our other communities, we define health as a community in a very holistic way. But I think in our languages, it is a very holistic concept, right? That your health is connected to um, the health of everyone else around you, and not just people, but also nature and land and ocean. And those things are inherently connected to how you see your health and your well-being. I think when you hear the word in English, though, it feels very different when you talk about health in our community. Most times, our community see health as long as you're able-bodied, then you have health and you have purpose to serve, and especially in the framing of being immigrants or being people that are not from here, it means that you have to work to make sure that your family has food on the table. So health is defined by that. If you're able-bodied and you're of sound mind according to yourself, and then you have a purpose to serve in your family and in your community, that's how health is seen in our community context. And so I think that that context also makes sense of a lot of the ways that we deal with health issues when they arise.
Thank you, Alisi. And Jack, about when health issues arise, right? How do cultural stigma, our community's experience around immigration, just perceptions from the community, our family and neighbors, influence how AAPI community members approach different kinds of healthcare, like preventive health, mental health, palliative care?
Well, to echo Alisi, I mean, a lot of our patients, for them, when they think about health and being healthy, is not needing to see a doctor, right? So a lot of the preventive care gets delayed until symptoms arise, right? And then we all know about mental health being super underutilized in the API community. And then one of the things that we have also been focused on is for the elderly. A lot of the end of life care is often avoided because of culture, because of the conversation. So a lot of this gets really avoided or pushed out. And I often joke because a lot of our doctors, by the time they see some of these patients with severe symptoms, it's already too late. And so, and the common denominator in that is that we hope to do more preventive care to our patients, giving more education, making sure that they can be able to access care. Because a lot of them try to avoid it as much as they can. They feel like, if I can work and I'm stable, I don't need healthcare. I don't need the services. And that's how they define that they're healthy and that and it's sometimes too late for them.
Thank you. And Zainab, speaking of what Jack was saying about educating the community, right, and having these conversations about preventive health and what it means to stay healthy and trying to educate folks about the different aspects of what that could mean, how do advocates and providers build trust and have these culturally appropriate conversations about health?
Yeah, I think a big portion of our education is really rooted in our cultural practices, and in a lot of faith-based outreach and education. Our model is really reaching the community where they're at. So we go to the mosques, the gurdwaras, the temples, and do educational workshops around common health issues that our community faces, so diabetes, cardiovascular disease, and other forms of health issues. And we try to frame preventative care and and also link our resources that exist. So availing the resources that exist, there's a lot of stigma around using public benefits and availing public benefits. There's also a lot of fear around it because of immigration and the current climate that we're living under. And so there are folks who are not receiving the benefits or seeing doctors or seeking care because of that. The other way that we are reaching community and providing education and resources is through health fairs. So throughout Southern California, LA County, Orange County, and the Inland Empire, we're hosting health fairs, some reaching over 200 community members who, many of who don't have insurance or are seeking or are not seeking care, to provide them with an initial consultation with the doctor and basic screenings, so that they can follow up and investigate if there is anything that comes up in those screenings with the doctors. So those are just some ways that we're reaching community. We're really trying to frame it in a culturally and linguistically sensitive way that community members are receptive to, because there's a lot of avoidance, I think, in the community as well. Kind of like what Jack was saying, was people not understanding until it's too late how serious their conditions could get. And so finding a way to, in a healthy way, in a way that is good for folks' mental health, to have the conversations.
Yeah, definitely. At what you were just saying about a lot of people don't really think about their health until it's too late, right? And it seems like an easy thing to push aside. And at AJSOCAL recently, we have heard a lot of growing concerns and misinformation from community members about public charge rule changes, CMS data sharing with ICE, even rumors that Medi-Cal or other public benefits programs are going to be completely eliminated. So can you guys all three talk about some changes that you're seeing from your populations that you serve due to these changes and how you're having to adjust for those changes, either for no-shows, decreased enrollment, hesitancy to attend events, things like that? We start with Jack.
Yeah, so a lot of changes are coming. A lot of FQHCs like us at CSC, we're anticipating major changes. We anticipate almost 25 to 30% of our patient population disenrolling or not being able to access services, which is a
Enormous.
huge burden to a lot of the safety nets. We do know that, these individuals, yeah, we've seen a higher tick in no-shows of people coming in. We've even heard people disenrolling from Medi-Cal because they were concerned that using the public, benefits would affect their application for citizenship. So we had an individual who was on life-saving medication, Eliquis, had heart failure. And I mean, it was just devastating to our team to hear that some of these individuals decided to disenroll Medicaid so that they could hopefully get a good decision on their citizenship application. So they decided to disenroll. The concern is that they may not even be able to survive once they get word from their application. So there's many of these instances where we are just trying to do as much as we can to educate them. There's so much fear going on. And again, it's also very difficult for us because we are considered a federally qualified health center. So that word in itself says, well, you guys are part of the government, right? We don't share our social security numbers. We don't share that information to the government. But there is a negative connotation for safety nets like us trying to provide education and try to give them a safe space. But we're just seeing a lot of individuals not wanting to seek care, just so terrified of what may happen to them because of the public benefits, because of the misinformation that's going on. We also have individuals who, I mean, there's so many changes now with re-enrollments, with enrollments. Our staff are trying to keep up as much as they can to educate the community, but there's just so much information, so much disengagement with what's been going on, and a lot of them are terrified to come to our facilities. They've heard, and we've all heard this. We've heard healthcare facilities being raided by ICE. We've had a couple of close calls at our facilities where they were right outside our doors. That communication spread like wildfire, and so we had a lot of patients not seek care because they thought that they would be targeted. So it's been very difficult for a lot of our facilities and a lot of our staff.
Yeah. Alisi, you want to add on anything to what Jack was saying?
Yeah, I think for our community, over the years in trying to do education around public charge, has been a challenge because I think one of the challenges for our communities that across Native Hawaiian and Pacific Islander populations are various immigration statuses. And so, we have from citizens to legal permanent residents to compact to free association migrants. Um, and also, we have a undocumented population in our community, those that don't have a formal relationship with the U.S., who come and oversee their visas. And so, I think for most of the time, what I've observed in doing public charge education for our community is that there wasn't even an awareness about public charge in the first place. I think most of our communities, especially in this time, are just either just making sure that they have care when they need it, oftentimes when it is a bit too late, or making sure that they have the care that they need when they need it and not raise any red flags around immigration status. Or we have a lot of our families on mixed status. We have kids that are citizens and then parents that might be undocumented who've been here for a couple of decades already. And so then there's just a lot of fear in our community, and we've been seeing that now. What I've found in doing public charge education before is that it actually drums up fear that didn't exist for them in the first place because they weren't even aware of public charge in the first place. So when we do this education with good intent of making sure our community is educated, it ends up adding to a layer of fear that already existed, and then adding to a lot of their own worries of seeking care because it's so difficult to navigate the healthcare system. And if you have a status that is unknown, like if you're a COFA migrant, most institutions don't even know what that is and what accesses they have, especially when that changes by administration, right? Like they weren't covered under the Affordable Care Act, then they were given access because of COVID, and then now it's under threat of being rolled back because of birthright citizenship issues and all those kinds of things that are happening today. And I think the overall observation for me is that there was already a lot of fear in our community because they're not getting the information they need to navigate an already complicated healthcare system. And now there's even more fear because of the attack on immigrant communities, to even seek care, and even for people who have mixed status families, there's even greater fear. So it's something that we're trying to figure out how to deal with. I think right now where we sit is to give as much information to our community as possible and try to support by navigating them to what they need.
Zainab?
Yeah, thank you, Jack and Alisi. These are all things that we're sort of facing as well. And in addition, I think we've seen, especially with the data sharing, folks who disenrolled and moved across county lines. Some moved out of state because of the fear of the immigration enforcement. And people are uprooting their lives because of what's happening. And another, I guess, nuance for our community that we've been having conversations with folks about around public charges. They've been waiting 20, 30 years to have their siblings come from overseas. And so any risk of them losing that opportunity is not worth it. And so we had a pregnant woman actually who disenrolled in Medi-Cal Vital Resources because of this reason. And it's devastating and unfortunate. And public charge has been in the, I guess, now environment for the last 10 years as a fear because of the past few administrations. And there's a lot of confusion because it was proposed, then it was not proposed, and we had a change in administration. And we're back here again at square one. And so folks who are US citizens, folks on green cards, and then folks who have unsatisfactory immigration status are all in this boat of, well, we're just not going to enroll. We're not going to seek care because I don't want to risk any chance of my siblings not getting visas or my parents or whoever it is. And so, and then on top of that, now there's like a pause for 55 countries, many of which who are South Asians who are not even getting approved visas. So it's like a double whammy in that way. But unfortunate, and I hope that things change, and that's what we're here for, is to make those changes.
Yeah, these are all like really, really salient points right now, and especially with the confusion around things like the data sharing and the public charge, in which things are changing so quickly. Some things are being proposed but not yet changed. Some things are, might already be in the process of changing. We don't know. And it's very confusing for us, not to mention community members, to figure out what's going on, and misinformation travels so quickly, right? But speaking of policies, how are federal policies, state policies, and even economic factors such as current inflation and medical debt increasing the healthcare cost burden for AAPI families, and what does that look like? We know that AAPIs are commonly thought of as, as relatively economically well-to-do, but we know that from yesterday's session and historically within our communities, the spread amongst AAPI communities is the largest of any racial and ethnic group. The highest income AAPIs are over 13 times more than the lowest earning AAPIs in terms of income. And so that discrepancy is higher than any other racial ethnic group and continues to grow. So what does that look like in the populations that you serve, and how they're experiencing these increasing financial pressures? And how does that show up in the way that they access healthcare and their healthcare concerns? Jack? Oh, Zainab.
Sorry, I can start us off. We've been seeing folks who like, first of all, disenrolling in dental care. That's a really big one, that they just can't afford the dental care, so that they disenroll in it. Similarly, for covered California, the price of these packages is astronomical, even for folks who have a stable income. Compounding that, the rising costs of gas, of housing, of food, it's becoming more and more unattainable and unsustainable for community members to have this extra burden of cost for healthcare. And so those are some things we're seeing. We're seeing a lot of folks who are seeking housing and rental assistance, as well as assistance for basic goods, food and clothing and toiletries, things that people use on a day-to-day. And so that, I think the increase in costs, plus the increase in I guess barriers to access healthcare is resulting in a lot of people also just not accessing it.
So, Connie, I think one of the major changes has been for impacting a lot of our patients has been recently the acid test rule. So in 24-25, California took that away. So it was just purely based on income. That was brought back. And so a lot of our patients have come back and so now they have either they're kicked off from Medicaid because of the acid rule, or they now have a share of cost. That share of cost is enormous for a lot of individuals. Uh, they will have share costs for Medicaid or for medical dental services that they used to not have to be responsible for. So now it's just a enormous burden for those individuals to now have to pay for the services. So we've had some individuals who, because of their acid test, now had to be kicked off to cover California, which is much more expensive for them. And so for them to even access services, don't even talk about dental services and medical services, everything now costs more money for them to, before it used to not have to, they didn't have any share costs, they didn't have to have copay. Now they're responsible for these payments. I mean, it's a real world effect where people are not showing up. They don't want to access it. They don't want to pay for it. Obviously, they have everything has gone up now, inflation. And so health is a back burner. And we're seeing that, with the expansion, and now it's a huge rollback, and it's a lot of patients are suffering because they weren't aware of this. And so this year has been a huge shift in a lot of our patients in accessing care because of just the acid test.
I mean, if I can add, Connie, you shared the spread of in maybe income marker or afford or what people can afford in our communities. And I can say with some confidence that our NHPI population is probably on the lower end of income earners, or how you measure people's ability to afford living. Um, some of our communities are some of our most impoverished under the AA and HPI label. And so cost has always been prohibitive to our community seeking care, healthcare particularly, which is why preventative care is something that has to be encouraged and um, affirmed and repeated all the time, because it's often when it's too late that they seek care, and it's often more expensive to seek care when it is that late. And so to add on all these other changes to healthcare policies, it just becomes even more prohibitive. It was already hard to encourage our community to seek care when they need it or before they need it. It's even harder now. And so cost has always been an issue for us. And then all these additional barriers are adding on top of that, with an even more unaffordable time for us to exist. So um, it has just made things worse for sure.
I think raising the asset test is a really, really interesting issue right now, right? Because all of us California, and so we live in an area that is quite expensive to live in, right? And so there's a lot of situations if people own property that's been passed down to their family for like a couple of generations, they might be like asset rich, but like actually quite impoverished in the way that they are able to live their day-to-day lives, right? And that is an issue in the way that the federal government determines what areas are considered impoverished and what populations are considered impoverished, right? The adjusted benchmarks for underserved areas determined by CMS is based on, for one point, like the housing assets of an area. And so an area that has high real estate costs like the South Bay, people are not considered underserved there, interestingly, because of the housing prices are high, so people must be well off there. So it is a very interesting problem that we have. And it's related to a lot of recent federal anti-fraud initiatives, right? We're so concerned right now, the government is so concerned about preventing fraud and whether or not people are fraudulently using the system, which it leads to all of these things like asset tests and such. So to pivot a little bit, Can you guys speak to the way these initiatives, like these anti-fraud initiatives, are creating additional burdens for your organizations, for your staff in terms of documentation and effort and staff time and capacity in terms of, and for community members trying to access services, like what that looks like?
I can say just on the in the enrollment process, an appointment that used to take 30 minutes is now taking up to 2 hours. And that with two staff members who are enrolling and serving, thousands of people in a year, that the time is to reach and to support people is now becoming more and more limited because of these anti-fraud initiatives that we're seeing through enrollments. Um, and also I think the confusion and that also increases the fear of for folks who are enrolling lots of more questions, lots of more inquiries coming in because folks have properties back home in their home countries and there's a lot more documentation that's required. And it's resulting in us having more questions to field, and then also more question or more time in these appointments and enrollments.
I second Sunny with that. Like, it has taken so much longer for our enrollment assistants to help with our patients. There's more documentation needed. It's also now it's more frequent verification. So you said it used to be a year, now it's 6 months, and patients are like they're so lost. A lot of our patients are so lost in being reminded what type of documentation is needed. And the disenrollments have just increased so much for so many individuals. So the barriers are even higher than what they were before. Um, yeah, it's been very difficult. And so oftentimes we have to, and again, most of this work is with our community health workers, individuals that they trust, individuals they can talk to, because a lot of this documentation is sensitive. Where do they place these documents? How do we make sure this is like sent safely? And so it's quite a much it's so much more work for these individuals plus our staff to make sure that they keep track of this. And we're seeing just yeah, so many more disenrollments happening because of lack of awareness or education or information. Sometimes we're just, individuals are too busy, and it's just a huge barrier.
I'll add to this by speaking to like what we've experienced as being as nonprofit staff. Um, I think it was challenging. We were started in 2020 in the midst of COVID, and so we had to train our navigators on how to like kind of paperwork and what the processes are. And so all of these changes has contributed to the how much more information that we have to train staff on, even for myself, even like I need to know as much as possible of all of these changes and how they would impact the work that our staff are able to do with our community members. And many times what we do, because we haven't had time to train everybody on the changes, is that we navigate them to places like a FQHC where we know they have greater capacity for helping community. The what ends up being a problem then is that there's more time. We have to do more trust building with who we're handing our community members to. And a lot of times that's where our folks just fall off. It's like, well, I was familiar with you, but if you're going to refer me to somebody else I don't really know, I'm not, and so that just becomes a huge barrier that we have to then overcome is like building trust, trusting that um, the whoever that we're referring them to is going to handle our community members with care. And so that becomes a really big issue is because we haven't had the time and the capacity to train up our staff on all of the things that have changed in policies.
Yeah, there's a lot of need for training and making sure that AAPI communities are being well served. Yeah. So, what are the strategies? Can you speak to some of the strategies that your organizations are adapting to respond to these changes while maintaining trust in the community and accessibility for your community members as much as possible?
I'll go quickly, because I've been thinking about this a bit. It's so hard right now doing this work, seeking funding to support the staff that are already knowledgeable and have been here and have shown commitment to serving community. I don't know what the strategy is to make sure that you bring funding to support the existence of the organization and the work that we're doing. But what I have pivoted to doing more in this past year, especially, is building stronger partnerships with people that already have the infrastructure to help our communities like FQHC. So I'm gonna be, like hitting up Jack and Chinatown Service Center to, make connections and really plug it into the some of our established organizations like the LTSCs and the SANs and folks that we know and trust their work and the way that they care for community. Because the if we can't do it, then we want to build a trusted partnership with other folks that have capacity that we can send our community to. So I think that's my strategy right now, is really like plug it into who's in community, like really strengthening that network so that we have people that can support our community members when they need it. That's it. I've at least figured that part out. Everything else, I'm not sure. Maybe Zainab and Jack.
Well, to echo Alisi, I mean, trust is super important, building that trust with partnerships. Connie, I think I mentioned this to you. As an FQHC, we used to rely on this program called 340B, which allows FQHCs like us to purchase drugs for our patients at a very reduced rate. We were hoping to use that program to offset or subsidize the cost for a lot of our patients when they're purchasing medications. We were hoping to buy for them. But unfortunately, there's a lot of administration changes. A lot of pharmacies are now opting out with that program. It used to be that all pharmaceuticals had to opt into that program so that we could be able to purchase those medications at a much reduced rate. Now we're seeing with this administration, pharmacies having the ability to opt out and not utilizing 340B really does hurt our chances with providing these much needed medications to the community. We have now partnered with UCLA and USC academic programs to see if we can be able to purchase these drugs at a more wholesale cost so that we can be able to provide these drugs to our patients. I mean, again, this only happened because we're learning that we are very limited in what we can do for our patients. Dental services as well. We're partnering with a lot of community dentists who wanted to volunteer because now we're seeing a lot more patients not able to access, not in July 1st, not going to be able to access dental services. So we're asking specialists to work with us. We're asking community dentists to work with us for free of charge or for a very low cost for CSE so that we can provide those services to the community at low cost or no cost. We're working with foundations. Again, it's just about making sure that we can build that trust and spread as much resources as we can so that we can take care of those individuals with no insurance. But we'll see. We hope that we can utilize as much as we can with our partnerships.
Just like what Jack was saying and Elise was saying, really leaning on resources that already exist. So similar to what Jack was saying about leaning on community dentists, we're also reaching out to doctors and doing more clinic-based models and health fairs so that folks who need the care can receive it. To a certain extent, it's unfortunately that we can't go and do cancer screenings in a clinic setting like the ones that we're trying to do, or health camp settings, but really leaning on existing partnerships and then building new relationships with doctors in the community who do want to give back, who do want to invest in the community, whether that be with their time, their skill, or their money. And really hoping that sustains us, but also the weight of the lack of funding for our organizations to continue on is also it's putting us in a very unique position of trying to keep the lights on, but also trying to make sure that our community is being taken care of. But the partnerships that we do have in this nonprofit world are incredible, and we're so grateful for them. And we are all learning from each other, and even like sessions like this are so helpful for our staff who can learn and understand different strategies, different or updates to policy and all of that good stuff.
Thank you, Zainab. We are so grateful as well to have partners like the three of you always. And on that note, let's close out with hopefully something a little bit more hopeful and forward-looking. Let's think about like in what we can do moving forward. What do you think are the changes in policies, in systems, in services that would make the biggest difference in improving healthcare access, affordability for AAPI and HPI immigrant communities? Alisi, you had a great answer when we talked about this before. I'm going to call on you to kick it off.
I will try to temper my enthusiasm about this. I think all of us that have been in this work know how iterative it has been to make changes to create greater access in many ways for health services for our communities. And it has become more clear now than ever before for me that we were just putting these band-aids on such a shattered system and in so many different places. And what I hope to see moving forward is that at least as a sector, is that we would stand behind like a universal healthcare or a single payer system that would allow everybody to have access to healthcare. Because we're constantly working on the access issue for our communities, and if it was already made to be affordable for everyone, no matter what, that gets rid of a lot of so much of the work that we've had to do over the years. And I hope that moving forward that we are more courageous and more clear-minded about how to fix this, because that one shift in the system could really change so many things and address years and years of work that we've had to do iteratively to fix something that was already so shattered to begin with. So shout out to Assemblymember Kalra for the courage to champion the bill that did not go through. However, I think many of us are seeing this more clearly, and I hope moving forward that we can be more that we can be louder and we can be more bold in standing behind a system that is more similar to something that is single payer or universal healthcare for our communities.
Well, I just want to echo it. The last few years, I feel like we had like two forward steps and like making sure everyone was covered, and now that was like a step back, and I just feel like yes, you're right, Lacey. We have to be more emboldened. We have to make sure that everyone gets care. We've done it. We've actually try to do that, and I think we can do that. But I think it ever more so. Our voices need to be louder. We need to. There was a comment about contacting our government officials. We've seen the support. We work with Congresswoman Judy Chu and Congressman Jimmy Gomez, who know how the residents and how the people are affected. They know it, and we really do need to continue to support their voices. But it's disheartening to see that we've kind of fallen back. But I really hope with all my heart that we can still move forward from what we've been facing in the last year.
And I think to supplement a little bit, the community organizing piece of getting the people who have the voice, who have the voting power, who have the ability to sort of put themselves on the line and speak up for those communities whose voices are being silenced more and more by the day. We're doing a lot of work around organizing our community, educating folks on different policies that are going to come into effect or that are on the table to be passed, and mobilizing folks to call their representatives. May Day was just last week, last Friday, and we had folks take up the streets. It's all interconnected, right? It's all really important work that we're doing the work that we can on the nonprofit level, on the advocacy level, at the state. But there's also our voices that can make an impact on the streets and in the community, and hopefully reach folks in power. And I also wanted to say that during the pandemic, we saw so many resources and so much potential being poured into our systems. You know, we were able to do this rapid response work and language access. You know, the counties were putting out materials in all different languages, and now we're back to that threshold language model where, you know, for folks who like the South Asian community, we're never going to reach a threshold where the county will publish our materials in language. And so it's just, I wish that we could go back to that model and really, like, we were able to see how the from the federal level to the local level, funds being poured into the community. And so it's possible, and it was evident that it happened. So why is it that we are back in a place where we're struggling again? It didn't have to be that way. And I think even having that viewpoint of, you know, we were there and like maintaining, and we can be in a better place, and it doesn't have to be this way, is really important. And I think that's part of our organizing model, is asking folks, what do you want to see differently? How can we imagine a world where we can walk into a doctor's office or walk into DPSS and there's someone who can speak Hindi or Punjabi or Gujarati, or an indigenous language, and get the support that they need.
Thank you so much. Yeah, I think all of this speaks to things that are possible and can be done. What is it going to take for us to get there, right? And I think a big part of that is working in partnership with each other and in solidarity with each other, right? Solidarity is an active noun. So thank you guys so much for sharing your perspectives. So critical at this point in time in which so many things are changing for healthcare access for our communities. We'll transition to a couple of questions from the audience. I know that we don't have very much time left, but we do have one question in the chat about class impacts to healthcare for AAPI migrants. So we talked about briefly, for people as a Filipino with professional migrant parents in healthcare, they are able to access healthcare easily, but also at times neglect their own health due to feeling like they need to constantly work. How do these factors look like for non-professional migrants? What are the pressures on them? Alisi, you want to start?
I think my answer's short here, and I had alluded to it already. For the majority of our community who have a hard time accessing healthcare, um, they just don't seek care until they really need it, until they need to go to the emergency room. And so then the emergency room becomes their entry point into healthcare, which ends up racking up debt for many of our families. That's the reality that we see. Because oftentimes, yeah, that's my short answer, is that they just don't seek care. And when they do seek care, when it is in dire need, it ends up becoming a financial burden for the entire family and sometimes the entire community. And sometimes even just loss of life becomes a choice over seeking care.
Yeah. Jack, do you have anything to say about how class affects how different immigrants seek care?
Yeah, preventive care is not in anyone's vocabulary. It's always like, as I said this before, no one wants to see the doctor until they need to see the doctor. They think they're healthy. And so screenings, cancer screenings, those are all like pennies on the dollar if they were to come in and get seen soon. If they go to the ER, thousands, tens of thousands of dollars. We try to educate all individuals to come in and get to see their PCP. We try to, again, it's what is their priority, and I think everyone is facing the economic challenges, and they're just unable to afford to leave their work to go see their doctor. We see that a lot, which is why I think telehealth has been both pro. I think there's cons to telehealth as well, but that access to a lot of patients being able to see their doctor through telehealth has been made it easier for them to seek care. But again, it comes down to each individual. I think everyone, you know, I mean, I was just thinking about my own parents. Like they don't want to see a doctor. They feel like they're healthy, and they have health issues, and they want to make sure that they can take care of grandkids and their children, and they just don't want to be able to ask for help. I mean, I think that's the mentality that we see a lot of our patients have. They just don't want to seek that help, and so it's costly. It's costly not just for the families; it's also costly for community hospitals, because it ends up someone will pay, and we just hope that they utilize preventive services, because we are the first in line and the cheapest and most effective care for them.
Zinab?
Yeah, I think also part of preventative care is lifestyle opportunities, right? So having time for meditation, having time to go on a walk, having access to clean and like healthy food, having the time to cook that food. I think those are all things that are factors um, in when you think about working class individuals who may not have the time or the luxury to access a green space, access a meal that isn't while they're driving to their next job or between shifts. So I think that's one component that I was thinking about was the lifestyle piece. Stress management. I think stress management can prevent a lot of things. Stress is one of the leading causes of cancer, the leading causes of a lot of heart issues and things like that. And so those are things that even accessing a therapist, talking to a therapist, something that we like is so hard for people who have even steady incomes. Accessing a therapist is very difficult. And so I think those are some things that I think are very clear between classes as well.
Well, quickly, last question. We just had one come in about telehealth, Jack, and maybe you can speak a little bit as a provider for how is telehealth a viable workaround for an in-person visit for AAPI communities, and what does that look like in terms of technology access, right? Like, are older adults able to use the technology to access the healthcare? Are lower income people who have older model phones able to have the software updates that they need to access that type of stuff?
That's a great question, and again, it's a double-edged sword. For telehealth, we saw a lot more individuals accessing care. They can talk to their doctor. There's a way to be able to reach your doctor without being in the clinic exam room. Transportation is always the barrier, so it's always taking time to get the patient into the exam room, and they got to check in and all that. So it has been able to, it's easier for them to access their provider when they need it. But there's also challenges. A lot of our seniors, a lot of them don't have the smartphones to be able to do. A lot of them, have problems with using Zoom, or we use Doximity, which is a telehealth We try to make it as easy as possible that they don't have to download any software for them to be able to access their doctor. And so we even have classes to train our patients when they come on site how to use Doximity. It's not just a text message. As long as they can like click on the text message, click OK, the software can be able to be uploaded without them downloading the software to be able to call it. So, but it took so many iterations to get to that point because I think we were using Zoom at first, and then you had to download. So it was difficult, but it did allow a lot of access to our patients, to their providers, and I think like that's also something that is also on the chopping block. There's been discussions about removing telehealth access to a lot of providers and care, so we're really concerned about that. But again, it's just a tool. There's pros and cons to it, but we've seen a lot of patients access their care for providers because they simply could not get off of work or they couldn't take the bus to our clinics. We often use Uber Health to get them transported, but that all takes time. Using telehealth, if they have the smartphone, then they're able to contact their providers. So again, it's just one of the things that we had to work towards during COVID, and we hope that we can continue to use telehealth for access to our patients. The only thing that with telehealth you can't do is physical examinations, of course, and so we do that as a requirement for our patients. They have to have a physical exam, but the follow-ups is much easier to follow up. So telehealth has been useful for that.
Okay, thank you so much for that, Jack, and thank you guys so much for being here, and to the attendees for joining us. I would like to remind everyone that AJSOCAL actually has an online health access resources hub geared towards people and consumers in California, but there are things about public charge and data sharing on there that are relevant to everyone. And we have the resources available in 13 Asian languages. So please go out there and check us out. The website is ajsocal.org/health access resources. And Jeff's going to put that in the chat for everyone. And definitely, please feel free to reach out to me, to Jack, Alisi, Zainab, if you guys have any additional questions or follow-up. Yeah, thank you so much. Any last comments from Marlies to wrap up?
Yes,
Thank
thank
you.
you so much. And huge thank you to our speakers and to all of you for joining us today. I want to also thank you all for all your thoughtful questions and for engaging with us in this really important and impactful discussion. In addition to the Health Resource Hub, which Jeff has dropped in the chat, I also want to uplift that we also have numerous resources and reports on our website, including the Community of Contrast, which was discussed yesterday. You can find all of that at ajsocal.org. We'd also like to encourage you to sign up for AJSOCAL's newsletter to stay up to date on the latest research, advocacy, and engagement opportunities. And then lastly, and should have mentioned it first, join us tomorrow again for the next segment of this series, AAPI Immigrant Justice, Seeing is Believing, English Not Required. The Zoom link for tomorrow's webinar will be the same as today, which you should have received in your email when you registered. And we hope you will join us there to learn more about AAPI immigrant experiences through media and what does it mean to engage with our communities from a communications perspective. The recording for today's presentation will be available on AJSOCAL's website after AAPI Immigrant Justice Series is complete, so please keep an eye on your inboxes for that link, as well as a link to a brief evaluation. We would greatly appreciate your feedback to help us make these sessions as useful and as impactful for you as possible. Thank you all again for joining us, and we look forward to seeing you tomorrow. Have a great rest of your day.